regulation, we mentioned that it's a complex set of processes by which cells control their functions, activities, responses to internal and external stimuli. So we mentioned that it is normal, natural, and it should happen if it's just responding to stimuli. But that response, the effect later can be good or bad. Good as in, this is normal, this is what it's supposed to do. When I have a cold, I build more mucus, I feel hot, I have a fever. Those are normal, natural. Or it could be abnormal when things go bad and now we have a possibility of cells losing their DNA function and becoming cancerous, right? So we talked about the cell cycle. I mentioned you don't have to focus on it as much, but understanding that, as someone mentioned in our little activity, that it's important to know that cells go through phases, and it's important they go through every phase properly. If there's an issue, it has its own system to check and balance or destroy whatever is the problem so that it doesn't continue to the next phase. But we mentioned in cancer, it loses that place where it's supposed to pause and stop and rest its replication is stage 0. And in cancer, as was stated, it bypasses all of those and just continues to replicate. Whether there's a good or bad something that's happening to the cell, it just continues to replicate and it goes out of control. Okay, so loss of cell cycle control is cancer cells, right? Another thing, increased proliferation. We said it's like multiplies so much, like it so much so that it crowds the area for other cells to do their job, right? We talk about the genomic instability, like the DNA is not doing its job properly. And we even mentioned how it is a genetic thing. So if there's going to be errors in the DNA, we're going to see functional differences and problems. We talked about resistance to apoptosis. We said apoptosis was what again? Who could tell me what apoptosis was again? I hear something here. Cell death, right? 2 points for you. So cell death as in once there's a problem with a cell replication, transformation, transcription, whatever, it can identify it and say, no, you're not the right way. You didn't replicate properly. You're going to go, right? It destroys it. It cleans it away. That's apoptosis. But in cancer cells, it loses that ability. And then there's the mitosis where we mentioned that's normal. All cells go through it. It's supposed to replicate. It has the ability to replicate every part of the cells, right? And it goes through like the overall, all the stages that we mentioned. Okay, so now more on the etiology of cancers, the genetic mutations, we mentioned that. Environmental factors, we said if a person is eating or certain foods where that's kind of like part of the lifestyle. Environment is more like pollution, cancer, like what would we say, like chemicals could cause issues where like maybe if their work environment requires that they use some kind of chemical, like people who use like I think place carpet, like the fume can be really strong, or if they work in a factory, if they make certain things, certain chemicals can really be a big problem. But in general, like if you live next to a factory, it's more pollution there than if you live, let's say, in a rural area where the air is clear and healthy. Lifestyle factors we mentioned, like a person who smokes a lot, right? Constantly irritating that area, it's going to cause inflammation, it's going to cause a reaction that eventually the cells are going to change to adapt, and that might cause issues. What else? So viral infection, like HIV, like the, what is the other virus we talked about? The Epstein virus, yes, right? HPV, all of those different viruses, they have a propensity to cause people to have cancer. And we talked about how sometimes when these cells have these manifestations, they release certain chemicals that are picked up in labs that indicate this is a marker for cancer, right? We talked about that. Okay, moving on. So another part we talked about was diagnostics. So how do we find out if a person has cancer? They're going to do a biopsy. They're going to take a piece of that cell and look at it under a microscope. What are they looking at? They're looking at the size, the shape, what are the characteristics of the cell that are not supposed to be there, right? Because we know, even though we're all different, our cells should look certain ways. Like a kidney cell should look like a kidney cell. A skin cell should look like a skin cell. So when they take it, Like, we'll learn when we have metastasis, right? So it could be a brain cell that metastasized to the liver. It literally looks like a brain cell, but they cut it out of the liver, right? So that's going to tell them something. So there's biopsies, right? Then we have the imaging. We said whether it's CT scan, MRI, it's going to show us size, shape, masses. We have laboratory tests, which is going to show us the tumors. We mentioned the enzymes that are released that will tell us this is a cancer something. We don't like this. Or it could be like too many white blood cells, too many red blood cells, too many of something that we know something is happening here. It's bad. Let's check into it deeper. And then there's a staging procedure where now we know they have cancer. What stage is it in? First stage, second stage, fourth stage, which we're going to see. So we have the different cancer staging, right? We have T, which stands for tumor, right? So we're looking at the size and the extent of the tumor. The N stands for nodes. We're looking at, did it get into the lymph nodes yet? Because we know that the lymph is like the sewer system of the body. And so if there's a problem, whether there's a problem or not, it's like clean out whatever it needs to clean out. So if it gets into the lymph node, it's going to travel. So that's why we're wanting to know if it's in the lymph node. So whether the nearby lymphs are being affected, and that will tell us that it's going to be metastasized. So now M is for metastasized, which indicates that it has moved to another organ or another tissue, right? And then we have the staging categories, which are, okay, so stage 1 means that it's just started, right? Then we have stage 2, stage 3, stage 4. So this is a progression, and it predicts the prognosis. If you're in stage 1, it's just started. It's tiny. They can possibly just cut it out, get rid of it, give you chemo or radiation, whichever they decide, depending on what the cancer cell is, and then you're fine, right? But once you hit stage 2, they have to do more, be more aggressive. Stage 3, and by the time you hit stage 4, usually they're like, there's nothing we can do, right? Short of a miracle, a person usually does not get out of stage 4 and be okay, right? So significant treatments are going to be required, as we mentioned, when any of the stages, right? So that we can be aggressive with it. Some cancers are more aggressive, so you can find it at stage 1 today, and in a couple of months, and it's like proliferated so much, you know, it's bad. So however stage they find it in, they're going to be aggressive with it, especially depending on what kind. So let's see. Stage 1 cancers are typically small and localized. Stage 2 cancers are larger than stage 1 and may have some limited spread to nearby lymphs. Stage 3 are considered locally advanced, meaning they have spread more extensively to nearby tissue or lymph. And stage 4 means there's metastasized of cancer. So both stage 2 and 3, stage 2 possibly in the lymph, stage 3 definitely in the lymph nodes, and stage 4 it has metastasized to other tissue. Now let's talk about the treatments, right? So treatments, the first one, surgery, right? I actually should have flipped it around, but we can start with surgery. So surgery, obviously you're cutting it out, right? And the reason why I should start with the others was because that's really not the first stage, right? Sometimes they will have to do radiation or chemotherapy to shrink it and then cut it out to see if they can get the most possible out, right? But when they go through surgery, it depends on if it's able to be cut out. Sometimes it's too big. Sometimes it's a different kind. So there's this one, if I remember the name, I forgot the name of it. So there's a cancer that children get that's on top of their kidney. And one of the things they tell us as nurses is do not palpate, do not massage it. And what that means is if they do, the way the cancer is, they're seedlings. They're like in this little sac, and they're tiny little seeds of cancer. And they're contained in the sac. So if you're massaging and by mistake you burst it, all the little seedlings are spread out, and there's millions of them. You can't go and take it out. So once they know that the person has it, the child has it, There's going to be a paper on the sheet, on the documents where the MAR that says do not palpate their abdomen because they don't want anything to happen to the, yes?
Is that Wilms tumor?
Wilms tumor, correct. That is the, thank you so much for that. 2 points for that. Thank you so much. So Wilms tumor, right? So we want to make sure that we do not palpate the abdomen for that. Okay, so nonetheless, that's going to be a surgical procedure where they're going to take it all out, right? But if it bursts, there's nothing they can do, okay? So then we have the side effects of that, right? Obviously, it's a surgery. So infection, wherever that organ, the issue, whether it's blood, well, usually if it's like a tumor, you cut, wherever that area is, it's going to be damaged. It's going to have an effect. So for example, if it's like the thyroid, right? And they had to cut something out. Well, it's going to affect your throat, because that's where the thyroid is. They're going to have a sore throat. They might have bleeding there, and then you're going to have to be like, okay, if you see a lot of swallowing, that means they're bleeding there. So there's a lot of things depending on where the place of the surgery was. So side effect of that. And there's also infection, okay? And then we have nursing considerations. According to where the injury, where the wound, where the surgery was done, would be what we consider as nurses. But our main consideration is we're worried about infection, we're worried about wound healing, we're worried about mobility, and we're worried about any complications that is connected to that organ, okay? So then we have chemotherapy. So the main thing about chemotherapy to remember is that it is systemic. When I say systemic, what do I mean? For 2 points.
Whole body.
I heard you say it first, right? So raise your hand for me. Right? So the whole body. So meaning every single cell is receiving it because it's running through the blood, right? So my eyes might be affected. So here's the places that are going to be affected the most. Here's the thing. Because it's the whole body, right? The cancer treatment is to do what? What would be the reason behind giving someone medication for cancer? Because fast-growing cells, what are we trying to do? Get rid of those fast-growing cells, right? So the chemo is to destroy that cancerous fast-growing cell. But since it's a medication that is running through my system, my blood, my whole body, what will it also affect? Every fast-growing cell of the body. What are some of those? Not the kidneys. Skin cells.
GI. Ear.
GI. I haven't heard it yet. I heard some, but what did you say? Hair cells. So I heard, stomach, right? So the intestines, right? So in the mouth, from the mouth to the anus, so we have a lot of nausea. We have a lot of sores in the mouth. Not the brain. Brain cells are not as quickly, right? We know they're not as quickly because if you damage your brain cells, you are out of luck, right? they don't replicate as quickly, right? But yeah, so the skin, so we can have sensitivity or the sores and things like that. So like the dermis and things like that. What else? We said the hair. So when a person shaves, we know or cut their hair, it grows really fast, depending on the culture or whatever. But mostly it's really fast, right? What else? We talked about the nausea with the stomach. We talked about the blisters in the mouth. We talked about the hair, skin cells. They lose all of it. So technically skin, hair is the same. They're bald. And was there something else? Yes. So I see your hand.
Does that include the liver?
No. So mostly it's the skin, the hair, skin, hair, the stomach.
Bone marrow?
Not bone marrow as much. They're not as fast, right? Blood lasts 120 days in your body, so it takes that much time to recreate a new one, right? So like that kind of thing. Well, they're constantly always, replicating, but not as much. Even, you know what? I should take that back because the fatigue. So yes, that is correct because the red blood cells, if they're being destroyed, so if you're fatigued, it's because it's destroying your red blood cells. You are correct. I apologize for that. So 2 points for him for me, please. What is yours? Yep.
I was going to ask if, since kids,
Mm-hmm.
when they're growing,
Mhm.
everything's going way faster for them.
Mm-hmm.
Does that mean chemo is way harsher on them?
So chemo is harsher on just anyone,
Yeah.
but because they're growing faster and they have a better prognosis
Okay.
because speaking of the brain, how as an older adult,
Their cells are more like resilient.
they're
compared to-
more resilient as a child,
Yes.
and they can adapt and change and become something else because they're still growing.
Okay.
Whereas adults, they've already decided what they're going to be, and they can't change it after the fact. But so like for a child who has, let's say, a cancer or something that's causing their brain to go crazy, they'll take that part out, and they will technically, it would mean that they've lost the function. But if it's the left side, the right side will pick up or do what the right side was supposed to do, the one that's gone, and they'll be fine. Adult won't be like that. They will lose that function completely. Yeah, but that's a great point. Give yourself 2 points for that. The idea that as a child, children with chemo will survive more than an adult might, right? Okay, so that's chemo. So those side effects, again, are according to the cells that are destroyed quickly. Again, the red blood cells, which is within the bone marrow that causes fatigue, and that was the one I was forgetting, fatigue. The skin cells, which connected to the hair cells. The intestinal, so that's nausea and the blisters in the mouth. And dang it, one more. What was the other one? What did I say? Hair, skin, GI, and red blood cells. So that's 4. Okay, red skin. Okay, cool. I saw your hand.
I was just gonna, so if the red blood cells would be considered, would also the platelets, so like bruising more?
I haven't heard too much about bruising, but I know the fatigue is a big thing. And that's why when he said stem cells, I was thinking about all of them. But like infection, I guess it would depend. It would depend on if it's leukemia, then there's definitely going to be that. But if it's general, then it's more the fatigue that I've heard more about than bruising and infections. Like they're more prone to that. But nonetheless, their immune system is lower, period. And so I can see that happening. Yeah, but I just haven't read that specifically.
Are these fast-growing cells like very important for us to know?
Yes, yes. So it's important to know that systemically, chemotherapy will affect those parts. Mm-hmm.
Staying in like pain control on top.
Right. So pain control, definitely, yes. But that's connected to just wherever the cancer might be. But the fast-growing cells are the ones we just mentioned. Yeah. Okay. So that's chemo. Now, so nursing considerations again will be connected to whatever that part is or whatever is happening. Which means what? So like if I know the person is going to be losing their hair, the nursing consideration is I'm going to recommend beautiful hats, wigs. I know that body image is going to be an issue, especially for women, because we know our hair is our glory, right? If nausea is going to be a factor, so I know, what do? Zofran, right? I'm going to give them prophylactically because I know for sure it's a factor. So before they even complain, I give it to them. I'm going to tell them, don't eat spicy foods, don't eat things that are, too flavorful because that can cause nausea. Just like in pregnant women, like when you say the smells can affect, right? So things like that, maybe. Bland food is better for them. What else? The sores in the mouth, I could tell them don't brush your teeth, maybe use swabs. So anything that's connected to what might be happening is what I'm going to consider and tell them and teach them about ahead of time. Then we have the radiation. The radiation is different because it's localized, which would mean that it's just affecting that specific area, right? So that specific area meaning, so if the cancer is, let's say, skin cancer in that specific spot, on the neck, on the leg, or whatever, right? Now, they will lose the function in that area, so hair might not grow back there again, which is different from chemo because the hair will grow back. Slow, more, I don't know, but nonetheless it will. But with radiation, it burns that area and it's destroyed. No more function there, right? But localized, as in, we're going to tell them, take care of that area. So don't put harsh soaps. Make sure you keep it dry and intact. Don't irritate it, that kind of thing. Now, if it is a pellet, right, that's placed inside of the body, there's a whole different thing. As opposed to the person going to a room, thank you so much, going into a room to get radiation, leave and go home, right? The person who gets the radiation in a room, leaves and go home, they're not radioactive because they left the radiation machine behind. But the person who they place the pellet of radiation inside of them, they are radioactive. That person's pee is radioactive, their spit, sweat, whatever, radioactive. And so they're not going to go home. If they have to go somewhere, it's going to be like a hotel. I remember one of my, I don't know, third, fourth removed cousins, she had, I want to say thyroid cancer, and they rented a room for her to be apart from her family because she said there was no secluded area for her, right? So she had a kid and she had a husband, but they placed her in a place because they knew that she needed to be apart from them. Yes?
What if you have like a cancer that's like either kidney or like colon cancer,
Mhm.
and there's like waste? You go get the radiation treatment and then you come home, but do you expel waste?
There's nothing. Once
Is it radioactive?
it's not going to be radioactive. If they're just, it's like a ray. The radioactive is in the machine, and the ray hits you.
Okay.
Once it retracts, that's it. No more radiation.
Okay.
Right? If at all, it might be like, not at all. There's nothing.
Okay.
No radiation.
Okay.
It's just if they put it inside your body. Yeah.
Okay.
But for like chemotherapy,
Uh-huh.
like at the hospital, they
Mhm.
have chemotherapy precautions, and then they say that when like the patient goes to the bathroom to cover it so
Yeah.
like nothing flies out.
Sure. So the chemical of chemo is extremely caustic, right? So it can cause damage. It's doing a lot of destruction in the body, right? And so it's just like a medicine where, just like if they say fentanyl, right? And they're like, don't handle it with your hands because it can absorb through your skin. So it's the same idea. Like, be careful because it's a chemical, and if you don't need it, you don't want it to touch you, you know? So, but it's not because it's reactive like that. But it can, because before they knew the effect of chemo, like nurses were dying because the chemical that was being released, like when they opened the bottles and when they did whatever they were doing, it was causing the nurses to get sick. And remember, even though it's not radioactive, it is carcinogenic. And so that can cause cancer too. You see what I'm saying? So that's the thing too. I saw your hand first.
Yeah, so with radiation therapy, since it is localized, if it's not anywhere near the hair, they wouldn't lose their hair.
No,
right?
they will lose the hair that area. So it's just that little spot. And sometimes they will put an X there to make sure that that's where they're going. And that's when we say, like, don't use lotions, don't use harsh soaps, just that area. So, like, if they had a radiation there, you can see, like, you won't see hair there, right? But it's not your own hair anywhere else.
And even like the pellet.
No, the pellet is different because the pellet would only be inside an organ. So usually it's in your bladder, right? So it might cause certain damage to the like bladder. It's like as it's healing. Okay, so you know how it's like benefits versus risks. So it's going to destroy the bad cells, but it might still cause some damage on the good cells up until the time they remove it. So anything that's radioactive, it's like the cure is worse than the medicine kind of thing, right? It's like I have cancer, but I'm getting something that can give me cancer to heal my cancer. You know what I mean? It's like, but it's like, it's gonna help me live 10 more years, or am I gonna, you know what I mean? Am I gonna die in 5 months? You know, so it's kind of like, they will have precautions to take for other people, but the damage that the cancer is doing to their body in the fast time, the speed, it's going to be worse than the gradual damage that the radiation would do because it's sitting there. You know, it's more gradual.
So would they only do the radiation if like the cancer's localized then?
Yes,
'Cause, like
yes.
if it has metastasized.
Yes,
it
it's going to
wouldn't
be, no, it's going to be chemo, for sure. And even some that are localized will still be chemo. It really depends on what the doctor feels the best treatment for this disease has been, right? So they could have a liver something, and it's like, that's just the liver, and they're like, you're getting chemo. Because it depends on the size, it depends on, it's a lot of different things for them to decide. But I know if the smaller it is, the more they'll lean towards localized because it's just a laser, right? The bigger it is, the more they'll lean on chemo. The stages also matter. The further along you are, because the thing is, it might look like, and I see your hand, Jay, it might look like it's just here, but we don't know, we're not inside the body. So the chemo, it circulates it everywhere. So anywhere it might be going to, it's going to kill it. You see what I'm saying? So it's like preventative, the more aggressive, chemo is more aggressive. So the more aggression you need, you're going to do chemo. The less aggressive, you're going to do laser. And surgery is only if I can cut it out. Yeah? So the doctor will decide. And we don't really care what they decide. All we need to know is why they're doing it, or what we need to do after they've done it. Yeah? Mm-hmm. Go ahead, Jay.
Is radiation poisoning common?
Is radiation what?
Poisoning common?
Radiation, so yes,
What was the question?
is radiation poisoning common? And what that means is, you know how when you have to wear the lead apron, every time you go get an x-ray, that's radiation. And so because they know that you can possibly absorb some of, and that's what that poisoning means, you absorbing some of that radiation, that's why they make you wear the lead each time, right? So it is very easy for you to absorb radiation and for it to hurt your body. And that's why they make you wear the lead apron. Yeah? Cool. Okay, so we already mentioned the side effects. They're localized to wherever that area is. The consideration are according to what is being done, but mostly it's like we said already, making sure we know the specific spot that's being radiated. So there's going to be an X marking it so they don't radiate anywhere else. Making sure that area, telling them it's sensitive, so don't use harsh soaps, don't use lotions, and don't irritate it, right? Things like that. And knowing that there's possibly loss of function in that area, possibly. Again, remember, it's like laser, so even if it's like a little part of the liver, it's not going to affect it as much as if it's the whole liver that's gone, right? Something like that. Okay, so then we have other samples. I see your hand, Renan. So we have targeted therapy, which is like targeted therapy focused on specific molecular targets in the cancer cell. And so those immunotherapy and hormonal therapy, again, nice to know things for our subject matter, but definitely read through it. So the targeted therapy, again, side effects could be skin rash, diarrhea, liver toxicity, and we want to educate the patient on being compliant, right, and making sure that they're taking their medication. What else? So the immunotherapy, again, it's trying to destroy the cancer cells. So depending on where it is, it can cause same kind of effects like flu, fatigue, and the consideration, again, educating the patient about the therapy. And then the hormonal, again, depending on what the hormone is that's causing. So if it's like ovarian something, or so it's like it's connected directly to the hormones. So a person who's menopausal or not menopausal, like that could be a side effect. Menopausal symptoms like hot flashes, vaginal dryness. So depending on what that hormone is for, you're going to have side effects according to that hormone. Raylan.
I was just gonna ask, when it comes to like the stages and the approach of things, would it be our job? Sometimes patients don't want to advocate for themselves. You know how when they're like stage 4 and the family wants them to do the therapy, and the doctor says to do the therapy, but it's making them more miserable for their last days. When is, like, how would you approach that?
So we never give opinion. We only tell them to get more information.
Okay.
So when we see that they're not doing well with something, we say, let's get the physician so he can share with you, more information on how you're feeling, why you're feeling it. And if you feel like you need to discontinue, it is our job to inform the physician of that.
Okay.
Because if they're scared to say, we're going to tell the doctor for them. But we can't say, oh, if you don't feel good, then just stop it. Like, none of that. But we can definitely relay that information to the physician so the physician can come back and give them more information.
Okay.
Now, we can share information like, yes, we know that you're going to be nausea, and this is why. You're going to, and let us know so that we can help. But if they need more information about what's happening to them outside of signs and symptoms, but pertaining specifically to the procedure, that's physician. Yeah? Any other questions? Okay, so now we talk about the symptoms, and mention was pain. So depending on where it is, what's happening, how it is affecting the body, discomfort, all of that. Fatigue, it starts with a J. Jordan, thank you. Jordan mentioned the fatigue. Janelle, sorry, you're Jordan. Yes, Janelle, Jordan. Okay. So sorry. So talking about the fact that the red blood cells are being affected. So red blood cells are our energy. So we're going to have fatigue. nausea and vomiting, we mentioned like our stomach cells, fast growing cells, right? And we know that because like hydrochloric acid is really like, would say destructive, right? But the stomach survives it. And so that's because it's being sloughed and it's rebuilding really fast. Psychological distress, nobody likes to hear that they have that diagnosis. It doesn't matter, right? So we're going to have to be there to be supportive. Sorry. To be supportive of them, right? And there are other symptoms too that we can look into, like constipation, the skin reactions, sleep disturbances. So there are different other symptoms that the patient might be feeling, which we will try to explain to them, help them navigate through it and see what they can do about it. Then we have the psychosocial care, which we mentioned with the emotional impact, getting them, what is it called? A chaplain, right, to talk them through it, helping them connect with their family, coping strategies, making sure they have positive ones, right, and not negative ones. And then we have the preventing the cancer itself, or like reoccurrence if they're in remission, right? And so we want to know like the different time frames for the different cancer screenings. Now, how can you manage to get screened earlier?
Like going to checkups, like.
Not quite just by going.
Is it like the annual checkups, like pap smear?
How do you get it sooner than the age?
Family history?
Family history. If someone in your family had that cancer, they will test you even 10 years earlier than the time you're supposed to, right? So if somebody in the family had prostate and prostate is like when age 50, they're going to test you at age 40, yeah? That kind of thing. Okay, so screening guidelines. So we need to know like the time frame. Let's see what else. So we have cancer prevention, so like tobacco control, health diet, physical activity, sun protection, alcohol, screening like mammogram, pap smears. So mammogram is age 40, pap smears is age 21, colonoscopy is age 50, prostate, I didn't write it here. So I'd have to look up prostate. I think it's 50, I think it's 40 as well.
Colonoscopy is actually 45 now.
Is it 45 now? Let me change that right now.
Mammogram's actually 30 now.
Yeah.
All right, so I'll look back in these. This is old. Say it one more time.
Colonoscopy is now age 45. Mammogram is 30 or 35.
Okay, I'll have to check that. Thank you so much.
And
And then I'll have to go back and see what age, yes.
Are these like, do you remember these ages?
So I don't do that. Because then if I tell you what to, then it's like,
wait, what was the question?
the question is, do we need to know these ages? So I will tell, when I say need to know, that's when I'll say need to know. Need to know means like, it's not going to be on the test, it's nice to know, but I won't say that for this and that because it's going to become too specific and I don't want you not learning. You know what I mean? Because that's just, I know it's a student thing where if I don't need to know it, I'm not going to, you know what I mean? And that's a dangerous place to be, yeah?
What was the other one you said? Mammogram, pap smear, colonoscopy.
So mammogram, pap smear, colonoscopy, prostate, and lung screening. They're in my notes. So once you open,
So I was gonna say that I don't think that everyone knows that because I had no idea. Janelle showed me how to do that, but I don't think that like people know that.
where the notes are?
Yeah.
Okay, I did mention the first class. So what we're gonna do is you're going to download the PowerPoint from Canvas. So if you just open it, it just will show you this, what you're seeing here. But if you download it, it'll show you my notes in the bottom, right? So yeah, make sure you download it. So thank you for that, Aspen. Okay, so then we have the lifestyle modification. So we're telling the person to lose weight because we know like when a person is obese, you know, it is a risk for cancer as well. So regular physical activity, because of the lack of activity, right? More activity is healthier. Sedentary is not healthy. So it's not like you're obese, you're gonna have cancer. It's not like that, right? It's just because you're not doing healthy things. It also means you're not eating healthy, that kind of thing. Avoiding tobacco, limiting alcohol, protection against UV rays, so that's like sunlight, And then stress management, right? So we already mentioned how stress can affect how our cells function. So reducing stress. So those are lifestyle modifications that will help. Okay, so that was on the general cancer, right? So that slide is all cancers. So if it's leukemia included, lung cancer, prostate cancer, kidney cancer, all cancers technically is the same thing, but the specific side effects will be according to the organ or that place, right? So now let's look at leukemia. Hold on, let's see. So that we can see an exemplar, right? That's what we're going to be tested on. So there'll be more questions, just to tell you, on leukemia itself than the actual cancer general questions, just so you know, okay? So we have, hold on, let me open this up. Okay, so you can read the class objectives. So the question is, how is leukemia an example of an alteration to cell regulation, and what is the effect of this alteration? So for 2 points, can someone tell me how is leukemia an example of alteration? One person, raise your hand. Go first.
It's the, it's the under baby white blood cells
Okay.
not completing the process of becoming like the actual white blood
Okay,
cells.
so give me a little bit more. Why is that an alteration?
Because if they don't complete the cell process properly, they're not going to do their jobs the right way.
Right.
So it becomes the immunity problem and all
Good.
the other.
So then the idea is what it's supposed to do is grow from baby to adult and do its job, but it's altered because it stops at a certain point and it doesn't grow any further, so it's not going to do its job.
And then
Perfect.
it also overtakes the blood.
And then crowds the other ones out.
Exactly.
Great, awesome. So now that goes into the next question is what is the effect of the alteration, which you also mentioned, so you get 2 points for that too, right? So what you can continue. What's the effect? You already mentioned it, but just restate it for me.
There's too many white blood cells, so there's a lack of room for the red blood cells.
Uh-huh.
So then we have the anemia.
Mhm.
Then it leads to thrombocytopenia.
Yes,
and-
great. So that's one of the ones, right? So we said that blood cells are created in the stem cells, right? And so red blood cells, white blood cells, platelets are in the stem cells. So if something's wrong with the white blood cells and they're growing too much, too many, too fast, it's not going to give time for red blood cells. So we're going to see that, yes, we're going to have anemia, but we'll also have infection because we said the white blood cells are not growing to maturity. So the way I think about it, right, I'm like, we always said our white blood cells is our defense system, right? So I think of soldiers' defense systems. I don't know if they're army men. Anyway, soldiers, right? And I'm thinking about there are ranks to this, right? You have the privates who are in boot camp and who don't really know what they're doing, and then you have the captains who tell them what to do. So white blood cells are supposed to come from private to captains. So in my mind, I'm like, they're all privates. They don't know what they're doing. They go to war and they're like, pam, 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 pam. They're shooting everybody, right? And so it's like, it's not very healthy. So you're either going to have like infections often, right? Because they don't know what they're doing, so they don't know how to do it properly, okay? Or you'll have stages where you're okay because they're doing the job, but not very effectively, and then you're not okay again. So it goes back and forth, and we'll see that. And then hit the next question for 2 points. Identify, oh wait, shoot, I just said that. Identify 3 priority assessments for a patient with a leukemia. Okay, I did mention it, but can someone tell me what that would be? Go ahead, Jay.
You want to monitor for any signs of infection.
Yes.
So you also want to check on the CBC, which
Yes.
is the UBC.
Uh-huh.
And I read it was the spleen might get enlarged.
Uh-huh. Okay. Mm-hmm. Yeah. So the enlargement would be an increase in either maybe because blood is stored in the spleen, so there's a lot of it, so it's going to be there. Okay. So I'll give you 2 points for that. Anyone else?
I remember in your video you focused on the fatigue, the bleeding, and the infection.
Right. So what would be some assessment? He already mentioned one, right? So
Seeing that they can't really handle activity.
yes, right. So they get fatigued. So I walk in the room and I see a patient and I'm like, he's really tired, like he doesn't want to do anything. That's an assessment I see something's wrong. What else could I see? Jay mentioned they have an infection. So like every time, and that's how you notice, like a little kid, kids are not supposed to have infections all the time. Like always having some kind of cold, some kind of flu, some kind of something. It's like something's wrong. You're going to check that out. That's an assessment. And then, go ahead.
Maybe for thrombocytopenia, they have low platelets,
Yep.
so it might cause some bruising.
Yes, so that's the assessment. Like, when you say they have low platelets, that's a lab. I'm not like, I assess, I'll go get a lab. But if I walk in and I see bruises, that's what I'm going to be going to tell the doctor, right? The doctor's going to tell me get their labs, and then I'll see the numbers. But if I walk in and I assess them, I'm going to see the bruise. I see your hand.
Because of the like emotional aspect from it, would we also want to do like a depression screening?
So that will be, but it's not part of like the leukemia itself. Like, because depression is like your brain, right? Like how it, but it still will be a thing. And so but it, like that could be anything, you know what I mean? But it's part, like I wouldn't pick it only because I feel like it's very broad, very general. If someone is depressed, that's not gonna technically tell me they have leukemia. You see what I'm saying?
Yeah.
The assessment has to be like more specific to leukemia. It'll be like a differential, you know what I mean? So, yeah.
I don't know if someone said this already, but weight loss.
Weight loss could definitely be one. Now, again, just like hers, it's not specific to leukemia, but because we mentioned that they're not going to be eating, they have nausea, they're going to lose weight. But it's not specific to leukemia. What's specific to leukemia is those three things. If a person has a lot of bruising, they're always tired, and they have a lot of infections, the first thing that's going to come to our mind is, do they have leukemia? And that's what we want to pick. We don't want to pick the other things where we're like, okay, they're tired. Like, I mean, even though we can say they're tired, or, did you eat today? Did you sleep today? You know what I mean? But if like three of those all together,
They're like listless and they just
right.
not properly respond.
So we want to be more
Kids are
specific.
way more active, so you notice that.
Hold on. So sorry, she was still talking, but I see your hand. Go ahead.
I said leukemia is common in like 2 to 5 years old.
Mhm.
And you're gonna notice that just coming from a mom, you'll see
Yes.
that in your kid.
For
and
sure.
then you'll notice like the difference
Right away.
instantly. because
Right away.
Most of
And-
the time they're just go.
And it's not even just children, but it's in any, because you know your body. You know what I mean? Like, when I was coming down with a cold, by the way, it's not a cold. I have COVID, sorry. But, don't kill me. But I felt weird, I was literally on the plane, right? And I was sitting in my seat, and I'm like, I just don't feel well, right? And I'm walking to the bathroom, like getting to the bathroom because I wanted to get away from the people. And then like literally as I'm walking, I drop to the middle of the aisle in the airplane. And I'm like, what the heck is going on? Like I can't move. And then I'm like, flat. It's like the worst thing, right? But my point is, you know your body. I knew something was wrong before it happened. So a child won't be able to tell you, but an adult will know like something's not right. I'm not usually like this. Right? So even in the beginning stages. Okay, I saw your hand back there. Remind me your name again.
Ariana.
Ariana, go.
I missed the third one. You said assess for bruises, always tired.
So it's fatigue, bruises, and infection. Yeah, go ahead.
So is leukemia mainly just in children, or can an adult get it?
No, definitely. Anyone can get it, but we're gonna see there's a specific type that's mainly in children. So let's move on so that we can get there. Yeah, but okay, so we have uncontrolled proliferation of malignant, immature white blood cells. So leukemia is specifically a problem with white blood cells, right? But we will have other issues because we say it crowds it out. So we just want to make sure that we know it's the white blood cells and they're immature. But we're going to see okay, so issues are going to be with the red blood cells because they're part of the stem cells too, and the platelets because they're part of the stem cells too. But the problem is the white blood cells, right? Okay? All right, so here's the different kinds that you're going to see. AML, CML, ALL, and CLL, okay? So these are the different kinds. We already mentioned this, how they differentiate. In the beginning, they're nobodies, nothings, and then they decide which ones they want to be. Now, it could become myocytes, eosinophils, neutrophils, and we'll talk a little bit about these, but not a lot. But in the stem cell issue, there's going to be a problem with the whether is it going to be a B cell, T cell, how it gets to it. Will it ever get to be a myocyte, right? It won't know what it's doing if it doesn't know it's a myocyte or if it's a eosinophil. See, that's the immature part, okay? Okay, so we have the differences or how the things that will tell us whether it's a leukemia or not. So exact cause, we don't know. But environmental factors we mentioned, and some of them are Philadelphia chromosome, benzene, ionized radiation, cigarette smoke, viral infection, chemo. So these are some of the causes that would possibly cause leukemia, even though we're not exactly sure anyone who gets it exactly what caused it. We already mentioned that there's a crowding of the bone marrow because there are other cells that were supposed to be there, right? So here we have the myeloids. So the the AML is uncontrolled proliferation myoblast. That is specific to it. Also notice the things that are in bold, right? That's in bold for a reason. The hyperplasia, right? Then we have the bone marrow and spleen, which was mentioned. Then we have age 67 is an average age of diagnosis. So we mentioned, like, it's not just kids. People will develop this around this age. And how do we know? Through their diagnostics, we're going to see the bone marrow aspirations. They're going to have the blasts. So blasts are immature cells. If you see blasts, that's what they mean, right? So they're immature white blood cells. So the CBC, we'll see platelets are low, red blood cells are low. Then the ALL, right, we have is 30%, so malignant transformation of precursor B cells. So that is specific to ALL. It's the lymphoblast in bone marrow or the blood is greater than 30%. And there's least common leukemia, most common in children, okay? And then we have the diagnostics of bone marrow. We have hypercellular, and then we can read that, right? The increased white blood cells, increased lymphocytes, red blood cells decrease, platelets decrease. CML, most common, adult leukemia. Strong association with Philadelphia chromosome, right? Predominant cell is the hepatopoietic stem cell, average age of 65. There are 3 phases, the chronic, accelerated, and then the diagnostics are, we're going to see the red blood cells are decreased, white blood cells increase, and the blasts are a lot. So genetic testing, we would do that. When we say genetic testing, what does that mean?
I was going to ask Steph.
Another question? Cool.
It's a test for family history.
Family history, right? If not just family history, but if they're going to have it, if it's been there,
Have the gene,
and if they're going to have the gene.
If their family has a gene, like to see if they're going to also have the gene.
Correct. Points for you. Thank you. Okay, I saw a hand back there, and then I saw your hand.
Acute easier to treat than chronic, or?
Oh, thank you for saying that. You should get 2 points for that. Okay, so acute is easier to treat, right? But you can die faster. The reason why it's easier to treat is because you can notice it faster. So the acute one is the one where they're mostly the baby cells, the blasts. Because they're mostly baby cells, they really don't know what they're doing. So that person is really going to have a lot of infection. So I'm going to notice it more because they're going to present with symptoms that's going to make them come to the hospital and say something's wrong with me. That's acute. They have more baby cells, so I get to notice they have a problem and I get to intervene faster. The chronic one, they will live longer, but they would die more assuredly because by the time I notice, it's too late, right? Because they have some mature cells and some baby cells. So the mature cells are doing their job and the baby cells are doing the crowding. So by the time they come, it's on and off, bad, good. And by the time it's already proliferated throughout the body, probably metastasized, and it's just too late. There's nothing I can do. So acute versus chronic. Acute is worse. I can die faster, but I can cure it more easily. And chronic, they will live longer, but once I find it, it's too late. They're going to die for sure. Yeah? Thank you for that.
More of a chance of
Does
being.
the,
Hold on. Go ahead.
does the acute and the chronic, does that apply to all cancers?
Yes. So in all of them, you'll see acute and chronic. Yeah.
Okay, I just want to make sure that.
All of them.
I was just saying, so you have a better chance with acute leukemias.
Yes.
Than you do.
Your prognosis of living is better with acute than chronic. Yes.
I'm sorry, you said this a while ago, but I think you said CML is more common?
Yes. So let's go back. So we have CML, we said, so that's not the one it's most common adult leukemia. So that's a CML that's most common adult leukemia. Then we said, which is the other one that's more in children, ALL is most common in children. So remember that.
I have a question. So, what
So usually that's the thing. So phase 2, stage 2, 3 is usually when it's going to be noticed. A lot of times, cancers are found accidentally, right? So like, just, you see how she says, I'm a mom, I know. Honestly though, are all moms very attentive? No, our mom's always there with their kids. No. So like, if somebody else is watching your kid more often than you are, you're not going to notice these different changes in their moods, their attitude, you know what I mean? Or you might brush it, oh, it's just a cold. Oh, you know, someone else, like, your kid has a cold, like, wait, like, I literally went home, and I noticed, like my mom is always taking people in. So, there was this family that's in her house, right? And I remember I went in Thanksgiving, and the boy was sick, right? The little boy, he's like 7. And then I come back again, and he's still sick. And I'm like, Mom, you know he's been sick for how long now? Did he ever get over the cold or whatever the heck he has? And my mom's like, oh, girl, that's not my problem. That's his mother. And I'm like, wait, what? Well, somebody got to figure out about this kid. So now I'm from California, and I'm like, Miss, could you leave your kid's passport this, that? I'm going to take him to the hospital, right? So, and she's not a bad mom, but like, she's really busy, you know what I mean? And she sees her son, but in her mind, she's not knowledgeable. And that's the other thing, right? You're in nursing school, so you're like cognizant of like some things I need to watch out for. For some people, oh, it's a kid thing, you know what I mean? So, but yeah.
Okay. Okay, so with acute, you said that it's like AML is most common with adult, and then
ALL children.
Is in children, but is that with chronic and acute?
It doesn't matter between the two. It's just that they're more common. Yeah.
Okay.
Yep.
Question about that too. So she was saying ALL for kids,
Yep.
CML for adults, but on the recording, when you were talking about CLL,
Mhm.
you said that was most common and it's diagnosed for 60 plus.
Okay. For which one? Which one did I say?
The CLL.
The CLL. Let's go back. CLL. So occurs mainly in older adults than older people older than 50. So I apologize for that. So go according to the slide. Yeah, I apologize. Okay. So we already mentioned this as we were closing, right? We said anemia, the fatigue because of the red blood cells that are being crowded out, they're not doing their job. The thrombocytopenia because of the platelets, we said that also are being crowded out, not doing their job, so the person is bleeding. And the infection. So now, really quickly, let's talk about a person has anemia, fatigue. What do I do?
Give them red cells.
Yes, you can do blood transfusion. If it's bad, you got to give them some blood because their body is not going to create it fast enough, right? However, if they do need to create blood, there is something that we need to do, and we'll see it a little later when we see oxygenation as well. So the kidney, right, has what's called erythropoietin, right, which is what signals the body to create blood. So when the body feels like it's hypoxic, less oxygen, or that it has lost blood, it's going to send a signal to the kidney to say, hey, send some enzymes, erythropoietin, to the kidney so that it can create more red blood cells for me. So the body will do it naturally, but if it needs some help, you would need to do blood transfusion. So that's great. But also, we want to do clustered care because you can't be coming in and out the room like that. So you want to do everything that you can that they can handle at one time, give them a break, and then come back, right? So that's a fatigue. Anything activity-wise, right? How about bleeding? What are some things I could do with them if I know that they're bleeding a lot? Or there's a possibility for bleeding? Yes?
Monitor eyes and nose.
Yeah, so I want to, how will that help me?
Well, to see where they're bleeding, if there's
So if I monitor I's and O's, what would that tell me? So I'm monitoring how much they're drinking and how much they're...
see if there's any blood and urine or feces.
Okay, so when we usually say monitor I's and O's, so what you say is monitor if there's bleeding in their urine, right? So if we are monitoring I and O's, that means we're seeing how much fluid is coming in and out of their body, right? But you want to see, okay, is there bleeding in their urine? Is there bleeding in their stool? So that's a good one, yes. Anything else? Mm-hmm.
You would check like when they're brushing their teeth. if they
Yes.
have
So
gum.
that's something I would tell them because bleeding gums is a thing, right? So I would tell them don't use a hard bristle toothbrush. Use a soft bristle toothbrush.
And no flossing.
And no flossing. What's another daily activity that causes bleeding in men a lot? Shaving. So I'm going to tell them not to shave with a Gillette, right? Or whatever, the razor. But they use electric razor, right? So that it less bleeding. What else can I tell them?
What about like activity activities that are like.
Yes, I tell them if it's a kid, kids love to be boisterous and really active. So I tell them no contact sports, right? How about something else? A mom, go ahead.
Avoid NSAIDs.
Yes, that's a great one, right? NSAIDs cause you to bleed naturally, right? So so how many people? So you had one, I'm not gonna give you yours. Sorry about that. So Aspen, Janelle, and you had one too. Didn't you have one? Okay, maybe not. Okay, so those are great ones. The NSAID is really good because you know what? When I walk into a room and a patient is bruising, what is the first thing I ask? Are you on NSAIDs? Because if they're on NSAIDs, do I do anything? No, because I know it's supposed to happen, right? But something else is women who are pregnant. What is something that happens to them a lot that they're like, oh, not the menstrual, constipation. And then that causes what? Straining, hemorrhoids. So what is something that I'm going to tell them not to be constipated, right? To make sure that they're doing, maybe not laxatives, but fibers, right? Okay, and the last thing, because we got to go. Yes?
What about the natural herbs or something you don't want them to garlic.
Sure. So you don't want, so the same idea about the NSAIDs, which is medicine, you don't want them to take anything that might cause bleeding or other issues. So you want to monitor the herbs that they're using. Is that what you're saying? Yeah. So great.
Would we see edema in kids because the lymphatic swelling and stuff like that?
Not as much. That's other issues will cause that, like nephrophlebitis or something like that. But the last thing, fever. Before we have, over time. So fever. What would we do for fever? Real quick. Cool them down. Tylenol, if they actually have a fever. Check their white blood cells. But how would we prevent it?
How would we
Prevent the fevers, like from infection. How would we prevent the infection?
Vitamins, restrict their contact.
Restrict their contact, right? Because we know other people might cause them to be infected by coming in, so they're visiting. We don't stop it, but we restrict it. That's the best way. What else? Hand hygiene. 2 points. Hand hygiene. Let's see. Mostly those are the ones. And just eating healthy, being hydrated, right? Yeah.
No, sharing anything.
Yeah. So kind of like the contact, but definitely, yeah. You I guess drinks and things like that. There's one more thing that they usually say. Go ahead.
Is it cooking the food completely?
So the food that people bring in, we would limit that, but not as much. But something else that people usually bring to the hospital.
No fruits.
Not the fruits.
Gifts. No fresh.
It has to do with gifts. Flowers. You said it. Chioma. Sorry, Chioma said it. Which one is it? Chioma said it. So no flowers because sitting water causes problems, right? Okay, we're done for now. Thank you guys. You're welcome. So I will be uploading this, right? It'll usually